Hello, listeners, and welcome back to another episode of the Donut of Destiny, the podcast on all things cardiac CT for anyone interested in cardiovascular imaging. My name is Praveen Ranganath, and I'm a radiologist in Dallas, Texas. Today, we explore the pros and cons of routinely performing calcium score CTs prior to coronary CTAs. I am joined by a friend and colleague, Dr. Vinit Baliyan, to dissect his research and thoughts on this matter. Vinit has published the results of a retrospective study from his institution in October 2019, and the title of this paper is False Negative Low Tube Voltage Coronary CT Angiography, High Intravascular Attenuation at Coronary CT Angiography Can Mask Calcified Plaque. Vinit, welcome onto the podcast, my friend.
Hi, Praveen. Thank you for having me. I'm excited to be here.
Yeah, man, it's good to chat with you again. Excited to share some of our thoughts on this matter. We know each other well, obviously, but I want the audience to kind of learn a little more about you. So could you briefly talk to us about your journey thus far in cardiac CT and where you are currently practicing?
Sure. I'm a radiologist, cardiovascular radiologist, working at Mass General Hospital in Boston. And my journey in cardiac CT started like roughly 7 years ago when I started my fellowship training at Massachusetts General Hospital. My residency training was back in India, and I came here as a research fellow in 2016. And then I transitioned into clinical fellowship, and I then continued something called as alternate pathway to American Board of Radiology certification. So I spent 2 years of my fellowship in cardiovascular imaging, and I have been performing cardiac CTs ever since.
Phenomenal. With regards to those cardiac CTs, have you always been performing calcium score CTs prior to those coronary CTAs?
Yes, that has been our standard of care. We almost always perform calcium score CT before the actual coronary CTA, except for select cases, like if it is a pediatric patient, young individual with the specific question of coronary anomaly and atherosclerosis is not the clinical question, then we do skip it, but we do it almost in everybody.
Got you. And to ask a slightly more technical question about that, for your routine coronary CTAs for the evaluation of, say, coronary artery disease, the calcium score technique you're using, is it a prospective step and shoot technique? Is it a flash mode technique?
It is a prospective step and shoot technique.
Perfect. Okay. So let's dive into a little bit of the paper now. As you mentioned in that paper, and I'm sure many in our imager audience is already aware, calcified plaque in the coronaries can be quite tough to differentiate from the iodine in the lumen at tube voltages that are low, for example, lower than 100 kV or so. Anecdotally at MGH, what percentage of patients do you scan at these lower tube voltages or tube voltages below 100 kV?
Yeah, I would say it changes because it depends on patient BMI. So I think in our practice, roughly 20 to 30% of patients do get scanned by 100 kV or lower.
Excellent. And there are some in our audience that are a little newer to CT technology. Why might a scanner automatically select a higher tube voltage relative to a lower one for a given patient?
Yeah. So a scanner, before doing the actual cardiac CT, does scout images, and based on that, it looks at the body's thickness and width. And based on those parameters, based on software programming, it decides which is the most appropriate tube voltage for that individual.
Got you. So it sounds like it's predominantly a patient soft tissue or patient body habitus contribution to what generates the scanner selected tube voltage for a particular coronary CT.
Exactly.
Got you. Down here in Texas, I will say that it is pretty heterogeneous in terms of anecdotally what percentage of patients we scan at lower KVs. At some places there are 0 that we scan at lower KVs due to Texas habitus related issues, but there are others in which I think it matches sort of what you're describing, around 20 to 30%. Was that right?
Yeah.
Perfect. Okay, perfect. So with this in mind, let's talk about what your study was intending to do. You tested this exact thesis that we may be missing calcified plaques at lower tube voltages. Let's talk about your study design and briefly highlight some of the key results.
Yeah, sure. So this was a retrospective study. It was performed on patients scanned between somewhere between 2015 to 2016 time period. So the rationale of the study was based on anecdotal observations. Like we saw, like in some a minority of patients where there was very little plaque burden, kind of it was really hard to see the plaque if we didn't have the help of calcium score CT. So we kind of having that hypothesis that it can primarily impact patients with low plaque burden, we kind of randomly mixed on one-on-one randomization. We mixed patients who had like a cadets 1 or 2 with equal number of cadet zeros, and we have like roughly 264 patients. And out of those, we divided them after mixing the cadet zeros with 1 and 2. We randomized, we classified them into 2 arms. One was low tube voltage, which is 70 to 90, and a high tube voltage, or standard tube voltage rather, from 100 to 120. And then the images were reviewed in 2 different sessions. In one session, only coronary CTA images were available to the reader, and in second session, both coronary CT and calcium source CT images were available. And they kind of the readers did 2 things. They counted the number of plaques and they assigned the final candidate scores per patient. And we observed that some of the plaques get missed in both arms, both in standard KV and low KV, but you miss much more plaque in low KV group than the standard KV, roughly like 40% versus 5%. And in a minority, like in most patients, because they have many plaques, so even missing like a few out of total doesn't change their CAD rates by much. But in a minority of patients, it does, because those tiny plaques were the only plaque that are there. So you miss them and you downgrade them to 0. So in that minority of patient, it leads to misclassification of the CAD rates.
Got you. So to summarize, it looks like at the lower KVs, at the lower tube voltages, more plaques are missed, particularly more calcified plaques are missed. This is on the order of 40% missed relative to 5% at higher tube voltages. With regards to the actual change in a CAD-RAD score or a surrogate for its clinical implication, really only at the lowest levels, for example, no plaque versus minimal amounts of calcified plaque, did it make a substantial difference. Am I understanding that correctly?
Yes. Yes.
Got you. So, with that in mind, can you walk us through why calcium score scans prior to coronary CTs can help address the potential pitfalls of scanning with lower tube voltages for a coronary CTA?
Yeah, so as we already discussed, like some of the plaque, they can look very similar, not exactly the same, but very similar in attenuation. And if they're like 1 or 2 pixel in size, it's hard to detect them when contrast is already on board. But if you have a dry run calcium score CT, you know the presence of plaque already, and that guides you to look at that specific area, and it helps you evaluate that plaque better. So it decreases the chances of missing that plaque.
Perfect. So I think we've addressed the pros to adding a routine calcium score CT prior to coronary CT. That said, I want to talk now about some of the counter arguments. So, in light of this, the SCCT actually published some interesting information in a recent survey, including data from almost 200 or so imagers on this exact topic. In this survey, we saw that nearly 40% of respondents do not routinely perform a calcium score CT prior to coronary CTA. A variety of reasons are given here, including additional radiation dose, insufficient additional clinical information, as well as lengthened scan time. So, are these counterarguments reasonable for not performing a coronary calcium score before a coronary CTA?
Yeah, so there is, some of the concerns are, I would say, a little bit reasonable, but I think there is more advantages of doing a calcium score CT than not doing it, because I think the major factor is, which I think is most reasonable, is it adds to the scan time, of course. but not by a whole lot. Maybe it adds 2 minutes or 3 minutes to every coronary CT, which takes like 20 to 30-minute time slot. So it's not a huge time penalty. There is a little bit radiation dose increase, but in the study that we are discussing, the mean radiation dose of in both groups, low kV and the standard kV, the radiation dose was like roughly half millisievert. So it was not like a high radiation dose with respect to the total radiation dose of the entire scan, including everything. So there is a minor radiation dose penalty, but the incremental information you get kind of justifies that in our experience.
Excellent. So it's a cost benefit calculus for whomever is going to use calcium scoring prior to coronary CTA. For me, at the institutions that I serve, it is heterogeneous. There are certain places in which we do routinely perform calcium scoring and others where we do not. In the institutions where we do not routinely perform calcium scoring, I have heard the same counter arguments of additional radiation dose, albeit minuscule, and increased scan time. While we can certainly discuss the merit of some of those counterarguments further, I want to move forward to another potential utility of the information you provided to the scientific community that's been discussed recently with regards to modification of scan parameters prior to scanning patients. As we had discussed in the beginning of our conversation, the scanners nowadays typically automatically select tube voltages based on its own interpretation, if you will, of a scout image. I have, however, seen the data from your study used to justify artificially increasing tube voltages of the coronary CTA portion of acquisitions to, quote, catch more calcified plaques. So, what do you think about this line of reasoning for trying to artificially bump up tube voltages to try to catch more plaque?
Yeah, I kind of disagree with this strategy because it kind of probably will add more radiation dose to the actual scan. Let's say if you increase kV from 80 to 120 in an individual just by like manually changing it, you could probably double the radiation dose of the scan. So if radiation was going to be, let's say, 2 millisievert, it will become 4. But instead, if you did a calcium score CT, it will add like 10% or 20% of the dose. So you're much better off doing a calcium score CT than altering kV manually.
Fantastic. So, is it safe to say that the scanners are better than us at selecting the scan parameters?
Definitely in the world of AI, I think that's a safe argument.
Absolutely. Absolutely. Great. Vinith, I think this has been really informative. It's given some perspective on why there is justification for performing calcium score CT prior to coronary CTA and addressing some of the counter arguments against that. Do you have any final thoughts before we close?
Yeah, so in a non-contrast, calcium score CT in our experience is a useful adjunct to coronary CTA. It helps directing your attention to the areas where there are tiny plaques that you would otherwise miss. And it's really important to know the presence of atherosclerosis. Clinical trials have shown, and they've argued that just by having the information that someone have coronary plaque can impact their future lifestyle and can potentially have impact on their morbidity and mortality downstream, like in Scott Hart trial. So having that information is key. So one can argue like the plaque that you miss is very tiny, and it's almost irrelevant in most cases because it hardly changes the CAD rates. But even in a minority, it is a vital information for a patient to understand that they have coronary plaque, and it has huge downstream implications in modifying their behaviors. And in long run, it can help saving some lives potentially.
Awesome. Vinith, thank you so much for your time. I think this has been a great conversation.
Thank you. Thank you for having me. It was great to be with you.
Of course, of course. And to our listeners out there, thank you very much for tuning in. Remember, if you like what you hear from us on the podcast, please take a moment to rate, review, and subscribe to us. This helps others out there find our content too. Once again, This is the Donut of Destiny. Cheers.